Hi, everybody. Good morning. Welcome back to Grand Rounds. This morning we have Dr. Janna Harland, who is Assistant Professor of Medicine in the Division of Geriatrics. Dr. Harland went to college, University of Colorado, and med school and residency, UT Southwestern, and did a fellowship in geriatrics here at the University of Colorado. She sees patients at the Seniors Clinic at Anschutz and also attends on the A service here at the University Hospital. She'll be speaking with us today about updates in geriatrics, and we're very much looking forward to this. So Dr. Harland, thanks for being here.
Thank you all so much for having me. We'll go ahead and dive right in. We'll bookend this morning with some pharmacologic updates. So we'll start out talking about some new Alzheimer's medications, lecanemab and donanemab. We'll then roll into hopefully some more clinically practical tips and tricks, some updates in statin use for older adults, some AGS Beers criteria updates from this year, including anticoagulation recommendations, and a bit about anticholinergic burden. And then we'll move through some practical tools for fall risk screening, assessment, and intervention, and wrap up with a brief bit about brexpiprazole. So we'll dive right in to the most exciting things going on in the world of geriatrics. Unusual that since I gave this talk in June, we've had actual big updates in the world of geriatrics. So we'll start off talking about lecanemab and donanemab, and just a reminder that these novel agents in the treatment of Alzheimer's disease are rooted in that amyloid hypothesis of Alzheimer's disease. And you can see here that lecanemab binds to the amyloid protofibrils, where donanemab binds to plaques a little bit later in the formation of these amyloid plaques, which then have downstream effects on neuronal function. So starting with the Clarity AD trial, which is lecanemab, this was a phase 3 multi-center, double-blind, randomized placebo-controlled trial that included 1,795 adults aged 50 to 90 years with a mean age of 71. These individuals had either mild cognitive impairment or mild dementia due to Alzheimer's disease, and were required to have amyloid confirmed either by PET or CSF testing. Notable characteristics from Table 1, you'll note that this group was more diverse than if you remember the aducanumab trials, but still were lacking diversity across this trial. And then you'll notice that the majority of these patients are in that mild cognitive impairment category at about 62%. Notably, about half of these patients were also already on treatment with either a cholinesterase inhibitor or other medication for dementia. And then the ApoE4 status becomes relevant as we're talking about both benefits and adverse effects of these medications. So just to make note of that. So primary endpoint in this trial was a change from baseline to 18 months in the clinical dementia rating scale sum of boxes. For context, this is an 18-point scale where higher scores indicate a higher level of dysfunction. And the baseline score at the start of the trial was 3.2 in both groups. So pretty low levels of dysfunction as we started this trial. And you'll see that both groups progressed. So we saw functional decline in both groups, but less decline in the lecanemab group, with that difference here in bold of negative 0.45. And so this is relevant when we look at our clinical dementia rating scale. This is what it looks like. It assesses 6 domains: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. This is administered as a series of questions to both patient and caregiver. And you'll see, if you sort of envision what a score of 3.2 to start is that's very minimal dysfunction. And when we think about what is clinically relevant, while the negative 0.45 change between the two groups on this study was statistically significant, a clinically significant change is considered to be 1. And for context, that 0.45 change is about what we saw in the trials for donepezil. When we think about harms with lecanemab, there were high rates of infusion reactions. And then the big thing that you'll see and have been seeing in press is this ARIA. So amyloid-related imaging abnormalities that come in 2 flavors, edematous changes and hemorrhagic changes. And you can see 12.6% versus 1.7% in the placebo group of edematous changes, and 17.3% versus 9% in the placebo group for hemorrhagic changes. There were no treatment-related deaths in this trial, but we did note a signal for increased harm, specifically in the ARIA hemorrhagic changes with anyone on anticoagulation, those with bleeding disorders, homozygotes with ApoE4 carriers, and cerebral amyloid angiopathy. So a lot of considerations there for who we should be including in this treatment. And then we'll move on, sort of review the donanemab trial, and then sort of bring it all together with some practical considerations for both of these drugs. So this trial, a bit more recent, so this was just published a couple months ago. This included 1,736 patients, and I mentioned that diversity in the lecanemab trial with a 71% white patient population. This was far worse at 91.5% white. So we're not doing well with recruitment of marginalized communities into these trials. You'll notice this is a slightly more female than male and just slightly older age population with a mean age of 73 years. There are a couple of interesting features of this protocol compared to lecanemab and aducanumab prior to that. One is that this protocol allowed for discontinuation of the medication once amyloid was cleared, which I'll show you in a moment. Amyloid clearing was quite impressive in this trial. And the other is grouping based on low, medium tau versus high tau prevalence on PET scans. And so we see this low, medium tau population that had slightly better effects as opposed to the combined population. Primary outcome here is a different scale. So we had the clinical dementia rating sum of boxes in lecanemab. Here we have the IADRS, the Integrated Alzheimer's Disease Rating Scale, which is a combination of 2 other scales. This ranges 0 to 144, and this scale lower scores are actually greater impairment. So in this trial, when we look at change at 76 weeks, so approximately the same length as the lecanemab trial, we see in that low medium tau group, which it seems they sort of parsed this out expecting better outcomes in that low medium tau group compared to the high tau group. We see a difference of 3.25, and in the combined group, a difference of 2.92. And for reference on this scale from 0 to 144, what is considered clinically significant is a change of 5 if a patient is in the mild cognitive impairment range. And these patients were all in the early dementia phase, thinking back to that initial diagram where we're intervening a little bit later in that amyloid pathway. And a clinical difference of 9 is considered clinically significant in that dementia group. So we're not quite hitting the mark with a difference of 3.25 in that low medium tau group, or a difference of 2.92 in our combined. On the other hand, when we look at amyloid clearance, this is quite impressive. So this drug, as well as lecanemab, are hitting their targets and they're clearing amyloid. you'll see on the right that 80% of patients had amyloid clearance in the treatment group by the end of the trial. And when we think about harms, similar with donanemab, so we did see infusion reactions at a slightly lower rate with donanemab compared to the lecanemab trial, but similar rates of the ARIA amyloid-related imaging abnormalities. So the edematous abnormalities occurred in 24% versus 1.9% in the placebo group, and the hemorrhagic abnormalities occurred in 19.7 versus 7.4 in the placebo group. Interestingly, this trial did report 3 treatment-related deaths that they attributed to progression of those ARIA changes. So putting all of that together, when we think about applying these drugs to our patient populations, big things that raise red flags or concerns for us. One is this overwhelming lack of diversity in our study populations. So our best study is 71% Caucasian with a better representation of Latinx and Asian populations, but still not reflective of our dementia population at large. This signal for increased harm and for decreased benefit in our ApoE4 homozygous carriers is a concern and brings into the equation the need for genetic testing and genetic counseling as we're preparing our patients to receive medications. There are huge access inequity concerns with these drugs for a variety of reasons. One is the financial cost alone, but the time-intensive and resource-intensive requirements of these drugs raise some big concerns. So when we think about cost, we're thinking about $26,000 for the drug. But in addition to that cost, we have a minimum of 5 MRIs required from onset of treatment through the year-long treatment course. We have infusion visits every 2 or 4 weeks. Lecanemab is every 2 weeks. Donanemab is every 4. We have a requirement for proof of amyloid pathology, which means we need CSF or PET testing, and physician visits throughout all of that to manage. When we think about resources required and this access inequity, we think about resources that we are privileged to have here at Anschutz, but our rural patients, our low-income patients may have a lot of difficulty accessing these resources. So that PET and CSF testing and ability to interpret those tests is required. We have to have expertise not only in MRI interpretation, but in interpretation of these ARIA amyloid-related imaging abnormality changes. Genetic counseling, as I mentioned, you've seen that the VA has approved these drugs or has approved lecanemab, and one of their exclusion criteria is ApoE4 homozygotes. So some of this signal for increased harm may mean that genetic testing and counseling is required and that we should not be giving this medication to those homozygotes. We need, of course, clinician expertise in mild cognitive impairment and Alzheimer's dementia diagnosis. And that's where we think about our general internal medicine, our family medicine, our primary care providers are going to be the first point of contact with patients who are interested in receiving these drugs. And when we think about those who may meet the criteria of MCI or Alzheimer's disease and filtering that huge number down to those who might be good candidates for this, the need for screening could be really overwhelming to the healthcare system. And then we need access to infusion centers and staffing to manage those high rates of infusion reactions. So from these trials, there are several outstanding questions. One of them is whether or not there's continued benefit beyond this treatment period. These trials were stopped at around the 18-month mark, and we saw really robust clearing of the amyloid on PET scans from both trials, but comparatively unimpressive clinical results. So are we looking at the possibility of continued improvement in function after the treatment period? That remains to be seen. The other big question is, have we given the drug early enough? We're already giving the drug in these trials at mildly symptomatic phases. The next question is that not early enough? Do we need to be giving these drugs pre-symptomatically? And there are trials now ongoing for asymptomatic patients with amyloid pathology, whether or not that will do the trick. We're hitting our drug target, but we're not seeing the clinical outcomes we expect. So the other question is, are we missing something with this amyloid hypothesis? And then the last big thing is, we don't know the long-term impacts of these ARIA changes. So you can imagine edematous changes, hemorrhagic changes in the brain may have similar adverse effects to some of the amyloid plaques and tangles that we're treating with these drugs. So a lot of questions remain with these medications. So taking a turn towards the more clinically relevant on a day-to-day basis, now we'll talk through some updates in statin medication recommendations. So we have a case here of a 79-year-old man with hypertension, preserved EF heart failure, mild cognitive impairment, prostate cancer, osteoporosis, severe osteoarthritis with impaired mobility, who requires a four-wheel walker for all mobility. He's been hospitalized twice in the past year, once for a fall and once for a heart failure exacerbation. He lives with his wife, who manages most of his IADLs in a single level home. He's a non-smoker and has no known ASCVD. Meds are an ARB, spironolactone, Lasix, a bisphosphonate, Tylenol, and Lupron. You can see vitals here. LDL is 158, and for ease, his ASCVD 10-year risk is 40.2%. So when we think about managing his ASCVD risk, we have a few options. So we can start a high-intensity statin, moderate-intensity statin, a high-intensity statin and aspirin, a coronary artery calcium score, or no change to therapy. So who's starting a high-intensity statin here? No one. How about a moderate-intensity statin? See a few brave hands here. A high-intensity statin and aspirin. And who's measuring a coronary artery calcium score? Not a soul. And then who is leaving everything as is, as geriatricians love to do? All right. So just a quick review, USPSTF updated their statin recommendations in 2022, so not quite as fresh as our Alzheimer's medications. And they conclude, as we would expect, that there is insufficient evidence to assess the balance of benefits and harms in initiating primary prevention statins in those above the age of 75. They're a little bit more firm on their aspirin recommendations, as you all know, and chose not to start that aspirin. So they are recommending against initiating low-dose aspirin for primary prevention of cardiovascular disease in those 60 years or older. When we ask the ACC and AHA, they are a little bit more aggressive, but not particularly in favor of committing to one pathway or the other. So we have a lot of very reasonable recommendations per the ACC and AHA. So they tell us that for those 75 years or older, with an LDL between 70 and 189, it's reasonable to initiate that moderate intensity statin. But they also tell us that in those above 75, it's also reasonable to stop statin therapy if there's functional decline, multimorbidity, frailty, or reduced life expectancy. And then lastly, they tell us in those 76 to 80, it's also reasonable to measure a coronary calcium score to de-escalate risk and avoid statin therapy for older adults. So we're left with a lot of gray area where everyone in the room is reasonably practicing medicine, but what is the best choice? Who in here is using ePrognosis on a regular basis in your practice? So this is a great resource that we use for a lot of different reasons in geriatrics, but one that can help us decide where along that fine line does this patient sit. So they have great prognostic calculators They have shared decision-making tools regarding cancer screening that can be individualized to your patient. And then what I'll highlight here is both the prognostic calculator and a time to benefit calculator, which is really great and an easy tool to use in the clinic room. So if we input this individual's different comorbidities into our prognostic indicator, we'll see that his 10-year mortality is 92%. And life expectancy is 2.9. And so you'll remember he had quite a few comorbid medical conditions, but this is largely hinging upon his decreased functional status and his functional limitations. So when we utilize this time to benefit feature, which is fantastic, and I recommend you all peruse, it has a whole number of different conditions, we'll see that he is kind of right on that line, where in the green, a patient is generally thought to receive benefit from a treatment. In the red, generally thought not to receive benefit from a treatment. And he's right on that cusp of a primary prevention statin, which means you all were exactly, as the ACC and AHA says, reasonable for considering that moderate intensity statin. This is a situation where you could use the coronary artery calcium score to de-escalate that risk. And if the score is low, to say we do not need that statin. Also reasonable, we're right on that cusp to leave medications as is and not initiate that statin. Theoretically, they exist. I don't know many of them. And then exciting news in the world of statins. I don't know who agrees here, but there are some randomized controlled trials examining this exact gray area where we have strong recommendations for those with cardiovascular disease. We have weak recommendations for those who are in this sort of gray zone. So we have primary prevention statin trials, the STARI and preventable trials, ongoing, assessing effective primary prevention statins in those over 75. More exciting, I think, in the world of geriatrics is this gray area of those who've been on primary prevention statins throughout the decades as our recommendations have changed, have no cardiovascular events, and now they're above 75 and we're not sure what to do with that statin. So this site trial was concluded in January but hasn't been published yet. And this is examining effects of withdrawing those primary prevention statins above age 75. So really exciting, hopefully with some answers on what to do with this gray zone of patients who've been on treatment for years, but still haven't had events. Shifting gears a little bit, we have a 92-year-old woman here with preserved EF heart failure, as all of our patients do, has AFib, had a stroke with residual right-sided deficits and foot drop, has type 2 diabetes, osteoporosis, and CKD stage 3. She was recently admitted with a fall after volume depletion related to diarrheal illness. She's on a bisphosphonate, a statin, a diuretic, and sitagliptin. You can see her weight and creatinine here, and her CHA2DS2-VASc for ease is 8. So she's coming to us now for post-hospital follow-up. Her anticoagulation was held during the hospitalization due to concerns related to her fall. And so we're here now as primary care deciding her AFib management plan. So we can hold anticoagulation based on that fall risk. We can initiate rivaroxaban for her, apixaban at a reduced dose of 2.5 BID, apixaban at a full dose of 5 BID, or tried and true warfarin. So who's holding anticoagulation based on that fall risk? Stroke, foot drop, a few people. A recent fall, all good reasons. Who's starting rivaroxaban? It's once daily, decreasing pill burden. No one's biting. Who is initiating apixaban at that reduced dose, 2.5? Great. And then who's doing full dose apixaban? And any warfarin loyalists out here? No, okay. So just a reminder, as we're thinking about stroke risk, bleeding risk, and falls and how those all kind of fold together, a reminder that our bleeding risk scores actually generally don't include fall risk. And so this sort of elusive fall risk as a concern for withholding anticoagulation isn't really captured in any numeric way. And there's little agreement even among these scores on what might constitute fall risk if we were to include that as criteria. So in terms of our bleeding risk scores, the only one that actually includes any reference to fall risk is the hemorrhages score, which is little used and highly flawed. Probably one of the reasons is that their definition of major bleeding is an ICD-9 code for hemorrhage, so not really sure what that constitutes. But when we think about our definition of major bleeding, it also varies among all of these commonly used risk scores. So when we think about HAS-BLED, which is used fairly commonly, those major bleeding definitions were any bleeding requiring hospitalization, which when a 92-year-old has any bleeding, they often end up in the hospital, a drop in hemoglobin by 2, or a bleed requiring transfusion. The Atria score narrows things down to a fatal hemorrhage, transfusion of more than 2 units, or critical anatomic bleeds. And when we think about which bleeds are we really concerned about that might outweigh the benefits of anticoagulation and that risk of major morbidity and mortality with a stroke related to AFib, really the bleeds that we're concerned about are those critical anatomic bleeds, those intracranial hemorrhages, and whether or not that risk outweighs the benefit of anticoagulation. And so when we think about where fall risk incorporates into that equation, this has been looked at time and time again. And the conclusions here are that those who are at high risk of falls didn't have a higher risk of major bleeds compared to low fall risk patients. So the conclusion being that being at risk of falls is not a valid reason to avoid oral anticoagulants. And one article did some math to estimate how many falls result in injury, how many of those are a head strike, and of those, how many result in intracranial hemorrhage, and do some fancy math for us and say that someone taking warfarin, which we know is higher risk of intracranial hemorrhage than our new anticoagulants, would have to fall about 300 times a year. So a daily faller for anticoagulation to not be the optimal therapy. So the general take home is that we really should be anticoagulating our older adults, short of some pretty compelling reasons not to. And then this brings us to our AGS Beers criteria updates. This iteration that just came out in 2023 sort of narrows down our choices further. And so they recommend to avoid starting warfarin, as all of you are already doing, but they also recommend avoiding rivaroxaban for long-term treatment of non-valvular AFib in favor of safer alternatives, and caution with dabigatran. And so really what the AGS has concluded is that apixaban, because of its ability to dose adjust for kidney function and weight, apixaban is the drug of choice when available for our patients for anticoagulation for AFib. And so for this woman, we'll initiate that reduced dose apixaban based on her weight of less than 60 kilograms and her age above 80. For our management plan for her AFib. We'll shift a little bit towards the concept of anticholinergic burden. So this is an 82-year-old woman with chronic hypoxic respiratory failure due to COPD. She has hypertension, coronary artery disease, depression, and urge urinary incontinence. And she's presenting to established care. Her daughter has a primary concern about her mother's memory loss. And her medication list is here. We see amlodipine, aspirin, statin, CoQ10, bowel regimen. She's on donepezil, Lasix, meclizine, oxybutynin, paroxetine, more bowel regimen, potassium, and Spiriva. So new this year in the AGS Beers criteria is a new drug-drug interaction between anticholinergic medications with other anticholinergic medications. And so this is a new category acknowledging this cumulative risk of anticholinergic medications leading to increased risk of cognitive decline, delirium, falls, and fractures. And when we think about the big players here, this is the table from the AGS Beers criteria of those with strong anticholinergic properties. Many of these come as no surprise to you all, TCAs, antipsychotics, but some of these sneak in that we use commonly in practice. Paroxetine is one that we see still used in older adults. All of our antimuscarinics for management of urge urinary incontinence fall in this category. Those antihistamines can be sneaky in some of those OTC meds. And then we see medications like antispasmodics that are often used, muscle relaxants, and commonly thought of as more gentle antipsychotics like olanzapine still on this list. If we look further, there are many iterations of this same list out there. This is not meant for you all to be able to read, but just sort of a general reference of many, many drugs with potential anticholinergic burden. And so the idea is that stacking these medications, one on its own may not have tremendous effect, but as we accumulate that burden, we have increased risk of cognitive impairment. So when we come back to this woman and think about how we're managing her medical conditions, her memory concerns, we see that she has not one, but 3 anticholinergic medications on that list. And this is also a really great example of the idea of prescribing cascades. We've given her anticholinergic medications, which have likely impaired her cognition, and we've then treated her anticholinergic medicines with a cholinergic medication. We've also created side effects of constipation and given her 3 bowel reg medicines. We have treated her blood pressure with amlodipine and created some lower extremity edema, for which we then prescribe furosemide and potassium. And you can see that this list of medications, if we remove or deprescribe all of those starred medications, we're looking at a much nicer, more concise medication list. So the last topic before we return to our medications with Rexulti, we'll talk about fall risk assessment and try to find some really practical tools for use in the primary care office. So this is a 79-year-old woman who has Parkinson's disease. She has depression, mild cognitive impairment, osteoporosis, and urge urinary incontinence. She's presenting for routine care. Since we saw her last 2 months ago, she's had 3 falls. She often feels lightheaded when she's standing and can't keep her balance. She's tripped while getting up to go to the bathroom at night. She lives with her husband in a single-level home. She does not drink alcohol or have any other substance use. You can see her vitals here. And her medication list: Tylenol, bisphosphonate, calcium, vitamin D. She has her Cinemet for Parkinson's, vitamin D, vitamin B12, some topicals, bowel regimen, donepezil, Lexapro, melatonin, mirabegron, and Preservision. So when we think about fall risk assessment, really practical tools are most helpful. This can be a really cumbersome process to really dig through fall risk assessment, intervention, and seeing outcomes. So CDC Steady, if you all are not familiar with these resources, is a really great set of resources for any setting. Includes clinical resources for providers, includes resources for community pharmacists to be involved in some of the medication evaluation, also includes resources for patients like exercise videos to help improve fall risk. So when we apply the CDC Steady algorithm, the initial step is fall risk screening, which most of our clinics are doing and doing pretty well. The next question is, what do we do when those screenings turn positive? So a couple of choices within this algorithm for fall risk screening. One is 3 key questions, which many clinics are already doing a version of this with MA grooming process. So this is feeling unsteady when standing or walking, fear of falling or worry about falling, and any falls in the last year. Easy, quick, very simple to integrate into clinic workflow. Another option is this Stay Independent 12-question tool, which is on the right side of the screen here. And this is a patient self-assessment. So another easy way to hand a sheet to a patient before a visit or to integrate into pre-visit questionnaires. Either of those, if positive, then turn us to our risk assessment. And really, when we think about fall risk assessment, this is a 360-degree assessment, but this CDC study tool really nicely breaks down discrete areas to evaluate. And so we're evaluating gait, strength, and balance, and they go so far as to give us common assessment tests that are quick and easy to do in the office space, like a timed up and go or a 30-second sit to stand. We're identifying medications that increase fall risk with a comprehensive medication reconciliation, and they refer us to the Beers criteria. They also have tools to engage our pharmacists in completing that aspect for us. They prompt us to ask about home hazards, prompt measuring of orthostatic blood pressure, visual acuity testing, looking at feet and footwear, vitamin D intake, and then identifying comorbidities. So using this tool and this sort of list of assessments, then they also give us interventions. And the recommendations here are the most high yield interventions from all of the literature about fall risk and improving fall risk. So we have recommendations for physical therapy or evidence-based exercise. We have recommendations for deprescribing, because we wouldn't be geriatricians if we didn't tell you to deprescribe. Supportive care for orthostatic hypotension, treatment of visual impairment, recommendations for shoe fit, and recommendations for management of other conditions, as well as recommendations for close follow-up to assess the impact of our changes. When we look at the AGS Beers criteria from 2023, this is the list of medications that are known to increase risk of falls and fractures. Anticholinergics, you'll remember, are in that category. Antidepressants are also here, with the caveat that we're weighing risks and benefits of those treatments and management of other conditions. We have antiepileptics, antipsychotics, benzos, and Z drugs, as well as opioids on this list. And like everything else, this list the risk is cumulative. So as we're stacking multiple centrally acting medications upon one another, this risk of falls increases. So when we return to our patient with Parkinson's disease, osteoporosis, urge incontinence, who's having frequent falls, we think about applying this CDC study algorithm to her specific conditions. Her orthostatic vital signs are wildly positive, related in part to her Parkinson's disease and in part to her treatment for Parkinson's disease. And when we review her medication list, we're not able to deprescribe any of those medications. The Cinemet is notorious for doing this, but it's also the thing that allows her to stay moving within her home. So instead, we approach this from a supportive care position and think about things like increasing fluid and salt intake, slow position changes, compression stockings, elevating the head of the bed. We refer for physical therapy as one of those evidence-based interventions for improving fall risk. We have occupational therapy as well in the home to do a home safety evaluation and assess for all of those fall hazards. She has low vision, and so we have a low vision clinic referral for her. She has very severe urge urinary incontinence, which we're managing with Botox injections as she's failed pharmacologic therapy. And then, as I mentioned, when we review her medications, all are sort of critical. So we're not able to deprescribe in this situation as we would like to. That's sort of a practical application of those CDC study algorithms to clinical care. And then last but not least, and we'll wrap up with plenty of time for any questions that you all have, is an update on brexpiprazole or Rexulti. And you may have seen in the news that this received expanded FDA approval in May of this year for agitation associated with dementia due to Alzheimer's disease. This is the first drug that's approved for agitation associated with dementia. The mechanism of action, this is a partial agonist at D2 and D3 and serotonin 1A receptors, an antagonist at serotonin 2AB and alpha 1B and 2C receptors. Interestingly, an antagonist at H1 receptors and has a threefold higher affinity than aripiprazole, which might account for some of the benefits of this medication. Cost, $57 per pill. Dose reduction is required with creatinine clearance of less than 60. And this has no change in the black box warning that we're all well aware of, so does come with increased mortality in elderly patients with dementia-related psychosis. The recommended duration of treatment of medications, of this medication in particular, is no longer than 12 weeks, which in clinical practice, we often see extended well beyond that 12-week mark. So still, with all of this taken into account, the recommendation is for caregiver support and education and non-pharmacologic management of dementia-related behaviors prior to initiating any pharmacologic agents. All right, that was the whirlwind tour of geriatric updates for you all.
Anticholinergics and dementia or is there thought to be a mechanism of somebody doesn't have cognitive impairment? I know there's been a sort of these large data sets. Is there any suggestion that they're actually positive, or is it just unmasked?
That's a great question. And for our online folks, the question is about anticholinergic medications and whether there's a signal that in a cognitively intact individual, exposure to those medications may be causative for cognitive impairment. And the answer to that is yes. There's emerging literature suggesting that early exposure to anticholinergic medications actually is a risk for developing dementia later in life, even in cognitively intact individuals. Whereas, you know, the traditional thinking is that they sort of unmask existing cognitive impairment or cause delirium, but the risk actually seems to be for long-term cognitive impairment as well.
Question about the monoclonal drugs for dementia. I was a little surprised that the VA covers those. You know, there's some caution about them. And it just seems to me as a non-expert that it is a nice example just to believe that. And so, how did the VA justify that with their cost constraints?
That is a good question for our online folks. Question about the VA's approval of these monoclonal antibodies and how they're sort of justifying the cost compared to minimal clinical benefit. The honest answer is I've no idea how that slipped through their, you know, they're normally financially quite tight. I suspect that the lack of treatment and the excitement around these drugs has something to do with it. But you're absolutely right. The clinical benefits don't seem at this point to justify the cost.
And that's one easy one.
Okay.
The easy one is remember, like in the last year or so, you did something about having people stand on one foot, the fall risk assessment. Is that any value?
The question is about standing on one foot as a fall risk assessment. I don't know, as a fall risk assessment, standing on one foot is a great balance exercise. So we will have patients do that at home. The standard directive is stand on one foot as you're brushing your teeth, switch halfway through, stand on the other foot as you're brushing your teeth. That alone can be extremely challenging for our patients. So it might require a hand on the counter and a 1 foot stand, but you can sort of escalate in level of difficulties. And then the hard question.
The harder question is, you know, this is kind of personal, but as someone with a parent going through Alzheimer's right now, I think the question I would want to ask, or would have wanted someone to ask me or try those is how long do you want this to last? That difference is not necessarily I don't know how often that question is this, but in terms of important consent for those kinds of treatments that are not going to be long. Will they last or won't last? The difficult question, obviously, with that, but it seems like the kind of thing clear about it.
And briefly for our online folks, this is a discussion around sort of the value of that small benefit in the monoclonal antibody drugs, and whether that amounts to prolonging the disease, but not ultimately altering the course of the disease, which is quite difficult for patient and family. And I think you're absolutely right. And I'll plug Dr. Dan Matlock, who you all know, and his expertise in shared decision-making is in the process of developing some shared decision-making tools around that exact question, thinking about similar questions that he manages with ICDs and LVADs. The similar thinking applies when we're thinking about, unless what we see is that those lines continue to diverge and we have long-lasting continued benefit from these monoclonal antibodies, which I'm not sure that we can promise. You're exactly right that the benefits and burdens of these treatments are maybe not equal.
Yeah, is it known the amyloid actually cause dementia or
I think that the question is whether amyloid is the cause or sort of a byproduct, and that is hotly debated for decades now. And I think that the impacts of these drugs on amyloid burden compared to that really minimal clinical change might speak to your question of whether the amyloid is the cause or byproduct here.
My understanding is that it correlates fairly strongly with cardiovascular risk. What's the level of evidence that reducing statins, for example, other things we know that reduce cardiovascular risk, any impact on it? We're looking at 50-year-olds, so I don't want to be Alzheimer's like parents. Is that another reason to argue for primary?
Mm-hmm. The question about atherosclerotic risk as a dementia risk factor as well. A bit of a complicated picture. There was a time when statins were thought to sort of contribute to cognitive impairment. We backed off on that. And then we run into the territory where most dementia at time of autopsy is actually a mix of vascular, we have Lewy body deposition, and we have these plaques and tangles. So most dementia is not just one thing, but multiple. And so at a minimum, with that vascular risk of microvascular or macrovascular disease, managing that with some of these primary prevention statins may give some benefit. And then we'll look towards our site trial to say, when can we stop those? Maybe after age 75, and continue to see good benefits there.
My question, you guys talk about obesity management or metabolic syndrome, what are the kind of the risks and benefits of weight reduction in a geriatric population?
We think of weight reduction sort of having a lot of benefit in that sort of pre-geriatric age. Once we have someone who is in that 75 and above age group, more weight or sort of higher BMIs is more protective towards other diseases that can be more life-limiting. And so we're not as aggressive with our weight management in my patient population, but having someone well managed up to that point then helps to improve mortality. So I think that these drugs are helping to get patients to us at a healthy weight where we then maintain rather than sort of promoting large weight loss.
Do you think it's weight or muscle? That's like
I think both weight and muscle mass contribute. We know when older adults lose weight, they tend to lose muscle mass, which is part of the reason why we don't aggressively promote weight loss, but they do kind of go hand in hand. You're right.
Question in the chat about what are you recommending for RSV vaccination? And then I'll add a question on to that. So the CDC recommends shared decision making when offering this vaccination. I wonder how you do that.
Great questions about RSV vaccines and what we're recommending and how we do shared decision making when every single one of our patients is above the age of 60. What that conversation looks like is many of my patients have already gone into the community and sought their RSV vaccines and come to me proudly announcing that they've gotten one, in which case I say, great, we've noted that in your record. What shared decision making for us looks like is really discussing what an RSV infection may look like and how that may impact this individual's life in a practical sense. And so talking to my patients with a lot of pulmonary risk factors is a bit of a different conversation than talking to my very healthy 80-year-old patients who are looking forward to a long season of backcountry skiing, but sort of detailing what that impact may be and helping the patient to navigate through whether or not the potential benefit of the vaccine is worth the risk and burden. And so sort of walking through in a more practical sense rather than kind of the statistics or numbers.